Hi guys, today's class is an extension of the earlier class where you learned about audiometry, right? And in audiometry you will be learning what is the type of hearing loss occurring, right? And to know what is causing that type of hearing loss, we will have to evaluate further. For example, if it is a conductive hearing loss, we have to know what exactly is happening in the mid ear which causes the conductive hearing loss. And if it is a sensorineural hearing loss, we have to know whether it is a cochlear or a retrocochlear hearing loss. All these can be evaluated by certain tests, and all that will be dealt with today. And I will be starting with impedance audiometry. And in this impedance audiometry, the primary purpose is to determine the status of the tympanic membrane and the mid ear. It is divided into two parts. The first part is tympanometry and second part is the acoustic reflex measurements. In the first part, what you are doing is you are actually giving a sound wave with the help of an oscillator. About 220 to 226 hertz sound is being given, and this is given in with the help of a snugly fitting probe with 3 channels, and one of the channels is providing this tone, and this tone which is being provided is going into the mid ear, and some of it is getting reflected back, and the part which is getting reflected back is being picked by the microphone. And also you have got a third channel which is connected to a manometer to change the pressure within the mid ear. So we are trying to assess how the change in pressure from plus 200 to minus 200 Pascal, that change in pressure, how is it affecting the mid ear? That is what we are we are looking for. Okay, now what are the various types of curves that are available when you are doing a tympanometry? In tympanometry, as I already told you, first of all, we are plotting a graph, isn't it? Okay, here you have the plus 200 minus 200. Okay, this is the pressure, and we will be trying to increase and decrease the pressure. When the pressure is normal, it has got maximum compliance. Okay, so we are plotting the compliance of the tympanic membrane against these pressure changes. So it is when the pressure on either side of the tympanic membrane is the same, the compliance will be the maximum. Okay, when the pressure on either side of the tympanic membrane is same, the compliance will be maximum, and that will be happening if the eustachian tube function is normal and if you are not giving any external pressure. Okay, so this we can keep it as the point of maximum compliance. Okay, this point is the point of maximum compliance. It will be nearly at the half of the y-axis. This point usually is seen. Okay, now how is the plot going to be seen? When you are increasing the pressure, the compliance will slowly come down like this, and similarly if you are decreasing the pressure also, the compliance further decreases like this. This is what is called the normal A curve. Okay, this is the normal A curve. Now if there is any ossicular discontinuity, okay, ossicular discontinuity, you know that the tympano-ossicular system is seen like this. You have the malleus here, there is an ingus and stapes here, right, and this is getting connected to the cochlea. Okay, so if this is the tympanic membrane, it has got 3 layers, right? Okay, now what can happen to cause a change in the compliance? One thing that can happen is the tympanic membrane can undergo atrophy. When does it happen? If it is a case of chronic otitis media, it can heal by forming a tympanosclerotic patch. That is one method. The other method is by self-healing. A healed tympanic membrane will have only 2 layers. In that case, it will be smaller, right? The tympanic membrane will be small. It will be a dimeric tympanic membrane that is seen, and it will be hypermobile. Or when there is an ossicular discontinuity here due to some cholesteatum or something, if there is some ossicular discontinuity, what happens? The stiffness will decrease, and because of that the tympano-ossicular system will move better. Okay, so the compliance will increase. So these are the two conditions where you can see an increase in the compliance. Okay, so that results in an increase in compliance, and the point which is maximum will be seen above, and that is what is called AD curve. And when you are increasing the pressure or decreasing the pressure, similarly you can see the drop like this. So this is the AD curve. Okay, now when you are decreasing the compliance, when is it seen? When is the AS type of curve seen? It is seen when the foot plate of step is fixed. That will cause an increase in compliance, right? Or if there is any fixation of the ossicles due to some tympanosclerosis, or if there is tympanosclerotic patches within the TM, which is increasing the stiffness of TM. Okay, when the stiffness of the tympano-ossicular system increases, that can result in an AS curve, and the compliance will be seen as reduced. Okay, that is what is called the AS curve. So the peak will be at another point, and it will be decreasing with the increasing or decrease in the pressure. Okay, now what happens if there is a eustachian tube dysfunction? With the eustachian tube dysfunction, there will be a negative pressure within, right? There is a negative pressure within the mid-layer. So what happens? With the negative pressure, the tympanic membrane will get retracted. The tympanic membrane is getting retracted inward. This is the malleus, ingus, and the stapes. Okay, now the tympanic membrane gets retracted inward, and here you have a negative pressure within the mid-layer. Okay, now what has to be done is you have to put in a negative pressure from the other side to bring in the tympanic membrane to the original position. The tympanic membrane would have retracted due to the negative pressure, and only if there is a negative pressure given from here, the pressure on either side of the tympanic membrane will be normal. Okay, so the point of maximum compliance, as I told, will be at a point when the pressure on either side of the tympanic membrane is the same. Okay, so that won't be happening when there is a eustachian tube dysfunction, because there will be negative pressure within the mid layer. Okay, so that negative pressure within the middle layer is a problem, and that problem has to be counteracted by giving a negative pressure. So when you are giving a negative pressure, what happens is that this curve will increase in compliance until it reaches a point of maximum. Okay, this point of maximum will be reached when the tympanic membrane goes back to its original position, and on either side when the pressure is the same, and that is the point of maximum. And after that, when you are giving further negative pressure, it will come down like this. When you are giving a positive pressure, it will again further come down like this, the compliance. And this type of curve is what is called the C curve. Okay, C curve. When there is eustachian tube dysfunction, there will be negative mid-layer pressure, and that will result in this C curve. Okay, and then there is another curve when the compliance is further decreased. Okay, here there is negative pressure within, but the compliance is the same. The negative pressure is present in the mid layer, but the compliance is the same. But if the compliance is also decreased, that can result in a B curve. Okay, how does this B curve appear? B curve will appear kind of like a dome. It is a dome shaped curve, because in B curve the tympanic membrane is filled with fluid. Okay, it will be the mid layer is filled with fluid, not tympanic membrane. The mid layer is filled with fluid, and the tympanic membrane will be very stiff and it can neither get retracted or come on the other side because of the pressure change, because it is stiff with the fluid within. Okay, and so that is why you are getting a dome shaped curve here. This is what is called the B curve. It is a dome shaped curve, and here you have a decreased compliance as well as negative mid-layer pressure. Okay, so these are the various types of curves that you have to learn in case of a mid-layer pathology when you are assessing. Okay, so from this you know that AD curve stands for discontinuity, oscular discontinuity, and AS curve stands for step-piece fixation. S for step-piece, and A is the normal curve, and C is the curve where there is eustachian tube dysfunction, and B curve means you are having fluid within the mid layer. It could even be a hemotympanometry, need not be due to the eustachian tube dysfunction. Okay, it could be a hemotympanometry where you have blood within. After history of trauma, you have to suspect that. Okay, so these are the various curves that you see here. You can see the A curve, AB curve, AD curve. Oh, sorry, this is the D curve. Okay, this is the AD curve. D curve you need not know. Okay, this is the B curve. Okay, now there are other things that are assessed along with tympanometry. What are they? I told you step pedal reflex has to be assessed. Yes, that is very important. Apart from that, you can also look for the external canal volume. Okay, and if the external canal volume is increased and if you are getting a curve similar to B curve with no seal obtained, that is indicative of a perforation. Perforation, the external canal volume will be seen as increased. Okay, whereas in case of a foreign body or wax within the external canal, the external canal volume will be seen as decreased. Okay, these are also pathology which will give similar to a B curve, but there won't be any seal obtained. Okay, now coming to the acoustic reflex. The contraction of stapedius muscle causes a change in the impedance. The minimum sound intensity to produce this is called stapedial reflex, and the acoustic reflex decay is occurring if a sustained tone of 500 to 1000 Hz is delivered 10 decibel above the acoustic reflex threshold for 10 seconds. If the reflex amplitude comes down to 50%, it is a case of abnormal adaptation, and it is a sign of the eighth nerve lesion. Okay, this is what is called acoustic reflex decay. Okay, there is something called tone decay you will be learning soon, but for now just remember that the acoustic reflex also can undergo decay because of the property of the nerve fiber for decay. Okay, so the sustained tone of 500 or 1000 Hz delivered 10 decibel above the acoustic reflex threshold for 10 seconds, that will bring down the amplitude to 50%. Okay, if it is coming down to 50%, that is an abnormal adaptation. In conductive deafness, reflex is absent as 70 to 90 decibel. It is not possible because of the conductive deafness, and in cochlear pathology, reflex occurs in less than 70 decibel because of recruitment. Now, what is this recruitment? It is the abnormal growth of loud sound, and that will be dealt with soon. Okay, and recruitment as well as tone decay are things which allow you to differentiate between a cochlear and retrocochlear pathology. Okay, in retrocochlear pathology, the reflex is at higher intensity or absent due to tone decay. Okay, now what are the applications of this acoustic reflex? It can be used to test hearing in infants and small children, to find malingering, to detect a cochlear pathology, to detect eighth nerve pathology, for lesions of facial nerve as well as lesions of brainstem. Now, how is it happening? It is a bilateral reflex, right? First of all, the sound is reaching the cochlear nucleus, and from there it is getting into the superior olive, and bilateral ears are getting stimulated. The bilateral stapedius is getting stimulated, and that is how you are assessing the acoustic reflex. Okay. What is the reaction time for stapedial reflex? The stapedial reflex or acoustic reflex will occur only if the sound to which it is exposed is less than 25 to 150 millisecond, because that is the reaction time for septal reflex. Or else if one is exposed to a loud sound at a duration less than this, the patient is sure to have a sudden sensory hearing loss because the sound is not getting attenuated. So the answer to this question is B, 25 to 150 milliseconds. Now coming to another phenomenon that you have to know, what is that? That is called recruitment. Okay, recruitment. What is this recruitment? You might be familiar with recruitment of police, soldiers, etc. Just like that, what is happening here? Here more and more nerve endings are getting recruited. That's why it got that name. It is a cochlear phenomenon. That is the first thing that you have to know about. This is a cochlear phenomenon, and this recruitment takes place as an abnormal growth in loudness. Okay, the abnormal growth in loudness of sound is what is called recruitment. Okay, so when a sound is being heard at low intensity, the patient is unable to hear. When the intensity of the sound is increased, it becomes intolerable. That is, it will be a disproportionate intolerance that is happening because of the recruitment. Okay, that is what is meant by recruitment, and this recruitment is the reason for the septal reflex. When you are looking, the septal reflex is happening at an earlier intensity in case of cochlear deafness. Okay, that is because of this recruitment. And how can you elicit this recruitment? You can do a test called alternate binaural loudness balance test. Okay, when a same intensity is given in an alternate manner in either of the ears, what is happening? When you give the same intensities alternatively in either ear, the sound which will be perceived will be different. Okay, that is, if it is in a case of cochlear deafness, it will be like this. Initially, for the same 0 decibel sound that is being heard, you can't hear on the right ear. Okay, you will need a 30 decibel sound to hear the same sound, but later on, by the time it reaches 80 decibel, that will be able to hear. So if the patient was having a hearing aid which is tuned for a 30 decibel increase in sound, he will be perceiving the sound as very loud because he will be hearing it as 80 decibel here. Unlike here, the sound will be perceived at a intensity 30 decibel less. Okay, so that is why it is happening. Okay, so that recruitment is a cochlear phenomenon. That is what you have to know. Now there is another test that you have to know. What is that? Short increment sensitivity index. Now why do you need to do this test? The short increment sensitivity index. This is also to look for recruitment. Okay, recruitment. How is it being done? A continuous tone is present at 20 decibel above the threshold. Okay, and it is sustained for 2 minutes. Okay, tone given 20 decibel above the threshold, and this is given for 2 minutes, and every 5 seconds increase by 1 decibel. Okay, and 20 such blips are given. Okay, 20 such blips are given, and when you are able to perceive each one of them, that is indicative of recruitment. Okay, so normally it will be only 0 to 20% that will be perceived, whereas in case of cochlear deafness you will be able to hear 80 to 100%. Okay, so CC 80 to 100% is indicative of cochlear deafness. Okay, and this cochlear deafness is seen in presbyocusis, Meniere's disease. Okay, these are the conditions where you see a cochlear deafness. Okay, now coming to threshold tone decay test. Where do you see a tone decay?